Many studies have demonstrated that behavioral interventions can slow the progressive behavioral problems and functional decline that accompany Alzheimer's disease. Behavioral interventions generally involve establishing a routine that provides both structure to decrease the cognitively impaired person's stress and flexibility to accommodate for normal fluctuations in cognition and behavior. It also involves modifying environmental conditions that contribute to disruptive behaviors or functional decline, strengthening environmental conditions that support desired behaviors and functional independence, altering the interactions between the caregiver and the cognitively impaired person, and providing immediate reinforcers when desired behaviors or functional independence occur. Successful use of these behavioral interventions is predicated on a comprehensive and ongoing assessment of the cognitively impaired person. I will use the term assessor to refer to the healthcare professional who gives guidance to formal caregivers such as nursing assistants or informal caregivers such as family members. This assessor must look for acute conditions that might underlie the problem behavior or functional deficit and then examine the cognitive and physical assets present within the person. When planning behavioral interventions for disruptive behavior or functional deficits, the assessment begins with a search for acute health problems such as urinary tract infections, dehydration, or constipation that might be causing the disruptive behavior or contributing to the functional decline. Other possible causes include pain, either acute, such as a headache, or chronic, such as arthritis, impaired vision or hearing, medications, fatigue, hunger, fear, and depression. Once these underlying conditions are identified, treatment of them may eliminate the disruptive behavior or improve the functional performance. If no underlying condition is found when intervening in disruptive behavior, the assessor next seeks antecedents or triggers, that is, anything that sets off the disruptive behavior. Triggers may include environmental factors, people, or time of day. Once a suspected trigger is identified, the assessor alters or modifies the condition in a stepwise fashion until the target behavior, the disruptive behavior, is no longer evoked by the trigger. The goal is to create a caregiving situation that is least likely to result in disruptive behavior. For example, the cognitively impaired person displays disruptive behavior in the community dining area, but the assessor determines that no undesirable behavior occurs if only 4 other residents are present during the meal. The care team then may alter the mealtime routine to provide a less crowded or stimulating environment for the cognitively impaired person. Or the assessor identifies that the cognitively impaired person screams when a shower is turned on. So instead they use a handheld shower head so that only the area being cleaned can be sprayed. Or as another alternative, a towel bath might be given. After identifying and modifying triggers, the caregiver next identifies reinforcers and distractors that are effective with the cognitively impaired person. Reinforcers are things that the person seems to enjoy, and distractors are anything that tends to draw the person out of a disruptive behavior. Reinforcers may include pleasurable food and activities, and a variety of reinforcers are needed so that alternates are available should the cognitively impaired person tire of the one being used. The care plan should reflect the top 3 to 4 reinforcers, and the lowest preference is used first so that the most potent behavior can be used if the disruptive behavior occurs. Non-food reinforcers such as hugs and smiles are preferable in most circumstances. Reinforcers are used when the behavior does not occur also. The care plan should also reflect the top 3 or 4 distractors. That is, activities that focus the cognitively impaired person's attention away when the disruptive behavior breaks through. In contrast to reinforcers, the most potent distractor is used first, since the goal is to interrupt the behavior as quickly as possible. Finally, the assessor must identify a plan for withdrawing from the cognitively impaired person should the disruptive behavior not cease when the distractor is applied. The caregiver simply withdraws from the person for a brief time so that no attention is given to the disruptive behavior, or delays the caregiving activity and returns later to carry out the activity. Planning behavioral interventions for functional deficits involves a slightly different assessment approach. Following the assessment for acute conditions that may be interfering with functional performance, the assessor next must identify the person's cognitive and physical abilities and deficits. 4 areas of cognitive functioning: attention span, language, sequencing ability, and judgment are particularly important for ADL task completion. The assessor should also ascertain the cognitively impaired person's gross and fine motor capabilities. This can be done by asking the person to follow simple commands such as touching one's nose, raising an arm, or tying a shoe. Since caregivers' behaviors often exacerbate functional deficits, the assessor must examine the caregiver's interactions and perceptions of the cognitively impaired person. Specifically, the assessor should determine if caregivers reinforce dependency to increase the cognitively impaired person's manageability and treatability, if they expect the cognitively impaired person to remain passive and to contribute minimally to self-care during ADLs, if they perceive independence as inappropriate for the cognitively impaired person, if they feel more altruistic if they do more for the person, or if they simply lack the knowledge of effective strategies to promote independence. Behavioral interventions that promote functional performance fall into 3 classifications. Standard strategies are interventions that are appropriate for almost all cognitively impaired persons. These include one-step commands, giving frequent verbal praise, providing reinforcement that is specific to the person, and anticipating the need for help. Problem-oriented strategies are interventions specific to certain impairments. For example, the caregiver intervenes in perseveration by replacing the repetitive movement with a purposeful action, such as handing the person a brush and initiating hair combing. Level of assistance strategies, the 3rd type, are interventions that mobilize latent functional reserves and are tailored to specific cognitive deficits. These strategies include stimulus control, verbal prompting, modeling and gestures, physical prompting, and degrees of physical guidance. The cognitively impaired person may know how to perform a task, but may have a motor apraxia that interferes with performance. So this person needs physical guidance to begin a movement. Another person may have problems with sequencing of actions and, for example, may need clothing laid out in the order that it will be worn. Many cognitively impaired persons have attention disorders and need verbal or physical prompts to maintain focus on a task at hand. Reinforcement of the desired behaviors becomes essential to the continuation of these behaviors. Because of impaired short-term memory, the reinforcement must occur immediately. In a recent study funded by the National Institutes of Health, the National Institute on Aging, we tested these behavioral interventions in a 5-group experimental design. Specially trained nursing assistants use the behavioral strategies during structured psychosocial activities or activities of daily living. I'm going to show you brief segments from baseline and post-intervention videotapes of one severely cognitively impaired, vocally disruptive woman. We found that our behavioral interventions produce similar changes in the majority of our subjects. What you will see on this tape is that the disruptive behavior of screaming decreased and that the woman's affective state improved.
Do you like babies? Hold the baby, look at it. Who's talking? Look down at the baby that you've got in your arms. Look how cute. Miss Thompson, what's the matter?
In other tapes of this same patient, we found that this woman's functional performance also improved. This videotape demonstrates that if behavioral interventions are used to promote functional performance and to decrease disruptive behaviors, the quality of life of patients with dementia can be greatly improved through the use of these behavioral interventions.